Good afternoon. I will be talking about gestational trophoblastic diseases, and this is the outline of my topic. Gestational trophoblastic disease is a general term used to include tumors derived from abnormal growth of your trophoblasts. These lesions would range from benign to malignant forms. So, what are trophoblasts? These are cells that form the outer layer of a blastocyst, and they are seen 4 days post fertilization and develop into a large placenta. There are three types of trophoblastic cells found in the normal chorionic tissues. First is your cytotrophoblasts. Second is your syncytial trophoblasts. And third, the intermediate trophoblasts. The cytotrophoblasts and syncytial trophoblasts would comprise the villous trophoblasts, meaning around the chorionic villi, while the intermediate trophoblasts are found outside the villous component or your extravillous trophoblast, particularly at the implantation site. The cytotrophoblasts are hormonally inactive, being the proliferating stem cell. They are polygonal in shape with round vesicular nucleus and clear cytoplasm. The syncytial trophoblasts are multinucleated cells formed by fusion of mature cytotrophoblasts, and they would produce your human chorionic gonadotrophin and your human placental lactogen. The intermediate trophoblasts are morphologically intermediate and between the two, and they are larger than cytotrophoblasts and are mononuclear. The different histologic categories are enumerated in the modified WHO classification. Those belong to the molar lesions are your hydatidiform mole, complete and partial, which is benign, and your malignant invasive mole. For the non-molar lesions, we have choriocarcinoma, placental site trophoblastic tumor, epithelioid trophoblastic tumor, which are all malignant. So what then are the risk factors for the development of your hydatidiform mole? First will be the age. So those younger than 15 years old or those more than 40 years old are at risk for hydatidiform mole. Those with a history of molar pregnancy will have a repeat HMOLE in 1 to 1.5% of cases and 18% risk of recurrence after a second molar pregnancy. Low animal fat and beta-carotene diet is also linked to hydatidiform mole. An accurate estimation of the prevalence of gestational trophoblastic disease is difficult because of large data variation, as hospital-based data will be higher in your referral centers. The incidence of hydatidiform mole has been reported to be highest in Asia, Southeast Asia, compared to Europe and the United States. It was reported to occur in 8 out of 1,000 pregnancies in Indonesia, 5 in 1,000 in the Philippines, and 2 in 1,000 in Japan. Hydatidiform mole is genetically abnormal conception and is considered a precursor lesion to your trophoblastic neoplasms. There are two types, your complete and partial mole, wherein each has a unique genetic makeup that gives rise to its distinctive morphology, clinical presentation, and potential for malignant transformation. Majority of your complete mole would arise from fertilization of an empty ovum by a haploid sperm that duplicates itself to restore 46XX karyotype, called your diandric diploidy. It is referred as an androgenetic because the nuclear DNA is exclusively paternal, even if the mitochondrial DNA is of maternal origin. In 4 to 15% of cases, fertilization of an empty ovum by two sperms would give rise to 46XX or 46XY, and they are called diandric dispermy. A 46YY karyotype is not known to thrive beyond a few cell embryo. In general, the excessive paternal and absence of maternal genomes would result in exuberant trophoblastic growth without your fetal components. What about partial hydatidiform mole? They are generally triploid, 69XXX, 69XXY, or rarely 69XYY with the abnormal conceptus resulting from fertilization of a normal haploid ovum by two haploid sperms, called dispermy, or by a single diploid sperm termed monogenic diandric triploidy. Like its complete mole counterpart, The excessive paternal genes in partial mole would result in trophoblastic overgrowth. However, the presence of your maternal genome would allow for fetal development, although genetically abnormal. The fetuses affected by triploidy in partial moles have multiple congenital anomalies and mental retardation. The partial moles tend to abort later than your non-molar hydropic abortion and may present as missed abortion between 12 and 16 weeks from conception. So how then do we diagnose? This is a diagram of the complete mole and your partial mole. So how do we diagnose molar pregnancy? First, by its clinical presentation, your sonographic picture, your beta HCG level, your histopathologic examination, cytogenetic studies, and your immunostaining. The diagnosis of molar pregnancy involves careful history and thorough physical examination. Once molar pregnancy is suspected, pelvic sonogram and beta HCG often clinch the diagnosis. The clinical history starts in a sexually active woman of reproductive age who presents with amenorrhea, and quite often she comes with a positive pregnancy test and almost always complains of vaginal bleeding in 97% of cases. The bleeding is described as prune juice in character that comes from patchy detachment of the placenta as a result of erratic trophoblastic growth and discorded invasion into the decidua. In some cases, these vesicles are passed out from the vagina. Physical examination would show marked discrepancy between the uterine size and the age of gestation. Unrestricted trophoblastic growth would lead to excessive uterine size in 50% of cases, with the characteristic ballooning of the lower uterine segment on internal examination, mainly due to the absence of your amniotic sac. Fetal heart tone and fetal movement are absent in some cases. A markedly elevated beta HCG produced by your proliferating syncytial trophoblast would lead to hyperemesis gravidarum in 26% of cases, preeclampsia in 27% of cases, hyperthyroidism in 25% of cases, but they usually become clinically significant in only 2 to 7% of patients. Hyperthyroidism is believed to be due to cross-stimulation of your thyroid-stimulating hormone receptor with your HCG. Acute pulmonary insufficiency may result from pulmonary embolism, congestive heart failure due to preeclampsia, severe anemia, hyperthyroidism, and even your IV fluid overload. Ultrasound has facilitated early and non-invasive diagnosis of molar pregnancy. It is the current gold standard of imaging tests for hereditary mole, wherein it would demonstrate the pathognomonic snowstorm or honeycomb pattern. The classic sonographic finding in complete mole is that of an echogenic mass with multiple cystic spaces about 3 to 5 millimeters in diameter occupying the entire uterine cavity. On the other hand, partial mole may present as a large gestational sac with a thick echogenic placenta-like echoes with sonolucent spaces within. And of course, you can visualize the fetus. Thicalotane cysts can also be seen on ultrasound, and it occurs in 15 to 46% of cases. They are seen as multicystic anechoic cysts, and they would spontaneously resolve within 8 to 12 weeks after a molar evacuation. Therefore, they are not routinely removed unless the woman is perimenopausal. The diagnosis of molar pregnancy is dependent on sensitive assays for HCG, which is a glycoprotein hormone produced by your syncytial trophoblast of the placenta. The other members of your glycoprotein hormone family would include your luteinizing hormone, your follicle-stimulating hormone, and your thyroid-stimulating hormone. Now, all glycoprotein hormone would consist of the alpha and the beta subunits, and the alpha subunit is common to all your glycoprotein hormone. It is the individual beta subunit of each glycoprotein hormone that confers its unique biological activity. Correlating your HCG level with sonography is helpful in arriving at an early diagnosis of hydatidiform mole. In normal pregnancy, The gestational sac becomes visible when the at HCG level of 1000 to 2000 MIU per ml and by your transabdominal scan at HCG level of 2400 to 3600 MIU per ml. And almost 90% of early moles are correctly diagnosed when your HCG level was above 82,000 and there would be no fetal heart movement as demonstrated by ultrasound. Serum HCG reaches maximum concentrations from 20,000 to 100,000 at 7 to 10 weeks and followed by a gradual decline till term. Any HCG level more than 1 million at any time in pregnancy or more than 320,000 MIU per ml after 100 days of amenorrhea may be indicative of your hydatidiform mole. So the measurement of a high HCG level, more than 100,000, usually suggests your complete hydatidiform mole. In contrast, your partial hydatidiform mole is less commonly associated with markedly elevated HCG values. Now we go to histopathology. Histological examination of the products of conception is mandatory, and this would usually confirm the diagnosis of hydatidiform mole. So essentially, a complete hydatidiform mole is characterized by generalized swelling of the chorionic villi, cistern formation with avascular stroma, and diffuse trophoblastic hyperplasia. On the other hand, partial hydatidiform mole consists of two populations of normal-sized and grossly hydropic chorionic villi. And compared to your complete mole, the trophoblastic proliferation in partial mole is focal. The edematous villi will also feature scalloping, trophoblastic inclusions, stromal vessels, and villous fibrosis. Next would be your cytogenetic studies. Cytogenetic studies are limited by the availability of fresh tissue and subsequent preparation of good quality metaphases for analysis. So DNA studies, which makes use of your polymerase chain reaction and short tandem microsatellite polymorphism techniques, can be used. Immunostaining can also be used in the diagnosis of your molar pregnancy. The use of your P57 KIP2 immunostaining alone or in combination with DNA flow cytometry could help confirm the diagnosis. Remember, during the early first trimester, moles can be difficult to differentiate from your missed abortion or hydropic abortion, even by histopathologic examination. We have to bear in mind that P57 KIP2 is a paternally derived and maternally expressed, so that its absence on nuclear staining would establish the diagnosis of your complete mole, with a positive staining seen only in partial mole and hydropic abortus. So this is a picture of your immunostaining. So this is a table differentiating the genetic and histopathologic features of your partial mole and your complete mole. And this is a summary of your diagnostic test for molar pregnancy comparing your complete mole, your partial mole, and your hydropic abortus. So how do we manage patients diagnosed with molar pregnancy? So we have 5 principles of management. First, anticipation and prompt recognition of medical complications. Second would be your timely molar evacuation. Third will be identification of women at risk for malignant degeneration. Fourth, post-molar evacuation surveillance. And fifth, post-molar contraception. So we begin with the recognition and treatment of medical complications. So as you can see, the medical complications seen would include anemia, preeclampsia, hyperthyroidism, electrolyte imbalance from hyperemesis gravidarum, pulmonary insufficiency, and even your DIC. So these are the baseline laboratory examinations we should order. If severe anemia is encountered, you have to manage this patient by blood transfusion. And preeclampsia, which occurs with the onset of hypertension, hyperreflexia, and proteinuria. Magnesium sulfate can also be given for the prevention of convulsion. but not routinely given because of the incidence of eclampsia is rare if hypertension is controlled. Patients with mild hyperthyroidism should receive propylthiouracil (PTU) and or propranolol as prophylaxis for thyroid storm prior to induction of anesthesia and molar evacuation. Resolution of hyperthyroidism may take weeks to months. So, women in their advanced age and those with large uteri are at risk for coagulopathy, such as pulmonary embolism, DVT, DIC, at any time of the molar pregnancy. We have to suspect respiratory distress when the patient exhibits agitation and confusion during or immediately post evacuation. So we have to remember that molar tissue can access large uterine venous sinuses at the time of evacuation and would cause these to embolize to the lungs to cause hypoxemia. So for the molar evacuation, the surgical management of pregnancy can be accomplished through suction curettage or hysterectomy with mole in situ. Blood components should be available prior to surgery. Complications such as uterine perforation, hemorrhage, and pulmonary insufficiency should be anticipated. Next would be to identify women at risk for malignant degeneration. So for this, we make use of Berkowitz scoring system for the high-risk mole. So a scoring of more than 4 is considered high risk for the development of gestational trophoblastic neoplasia. And for these women who are at risk for malignant degeneration, chemoprophylaxis may be given. And according to the Philippine Society for the Study of Trophoblastic Diseases, they can administer chemoprophylaxis among high-risk patients provided that they have fulfilled the following indications: age of more than 35 years old, excessive uterine size, more than 6 weeks larger than age of gestation, presence of fecalotane cyst of more than 6 centimeters, presence of your medical complications, if this is a recurrent molar pregnancy, or if you have serum beta HCG level of more than 100,000, or if this is a documented hereditary mole with coexisting normal twin, or if the patient has a poor follow-up. So agents commonly used would include your methotrexate, which is the preferred agent, given at a dose of 0.3 to 0.4 milligram per kilogram per day for 5 days, and actinomycin. Now, the mechanism of action of methotrexate is that it interferes with thymidylate synthesis. It specifically inhibits your dihydrofolate reductase, which then blocks the reduction of dihydrofolate to tetrahydrofolate. This blockage in turn inhibits the formation of thymidolates and purines. Thus, it can arrest your DNA and RNA and protein synthesis. The fourth principle of management is post-molar evacuation surveillance. This is with the objective of detecting post-molar gestational trophoblastic disease. For we know that the risk of post-molar tumor occurs in 15 to 25% of cases after a complete mole and 0.5 to 4% of cases after a partial hydatidiform mole. So a baseline serum beta HCG is determined prior to molar evacuation. So whether a complete or a partial mole, all patients should be diligently monitored post-operatively with weekly or bi-weekly serum beta HCG level until the value reaches normal for 3 consecutive weeks. And patients are advised to avoid pregnancy in the succeeding 6 to 12 months following normal beta HCG in order to allow ample observation time for the development of your post-molar GTN. We have to remember that 30% of your first menses are ovulatory, and the median time to ovulation after evacuation is 9 weeks. And in 5% of cases, ovulation has occurred when the beta HCG is less than 100 MIU per ml. And in 60% of cases, ovulation would occur when the beta HCG is less than 10 MIU per ml. Thus, there is a need to use a reliable form of contraception. So the patients are advised to use effective contraception, and the recommended method is low-dose combined oral contraceptive pill. This has a low pregnancy rate and does not increase the risk of post-molar disease and does not affect your beta HCG regression time. So, for patients who may not be able to tolerate oral contraceptive pills, progestogens in the form of depot-medroxyprogesterone acetate or an implant may be used. And we have to remember, IUD should not be used prior to achieving the normal levels of HCG because of the risk of uterine perforation. The post-molar patient should be advised that there is no increase in the incidence of stillbirth, prematurity, congenital malformation, and abortion. However, in general, patients with HMOLE should be reassured that subsequent pregnancy outcomes are similar to the general population. And you also have a risk of a second molar gestation in 1 to 1.5% of cases after a previous molar pregnancy, and after 2 molar pregnancies, the risk is increased to 18%. After molar pregnancy, the products of conception or the placenta of subsequent pregnancies should be submitted for pathological examination, and the serum beta HCG level should be determined at 6 and 10 weeks postpartum to check for occult GTN. This is just a table giving us a summary of the principles of management. Now, referral to a trophoblastic disease specialist is warranted if you encounter 5 of these, any of these. So, a plateau of your HCG level for 4 consecutive weekly measurements over a period of at least 3 weeks, a rise of your HCG level for 3 weekly consecutive measurements or longer over at least a period of 2 weeks, if you have a histologic diagnosis of choriocarcinoma, or if you have a persistently elevated HCG level for 6 months, and of course the presence of metastatic disease. So that ends my lecture for this afternoon. Thank you and good day.